traded health and supplemental benefits companies. With this, we have a long-standing commitment to Louisiana that's evidenced by the presence of some of our most talented and energetic associates, many of whom are part of our conference today. We understand that we are in a competitive market, but as one of the 4 identifiable leaders in the state, we are confident that we are making a difference in the market. We hope to see Louisiana continue to do well, and we hope to be a part of all the good things that the future can bring. Over the past couple of years, Humana has made a number of changes around implementation regarding healthcare reform. While it's impossible to cover a nearly 3,000-page law in just one day, many of our presenters today have done their best to highlight the major impacts, the hot topics, and the highest profile provisions. Looking ahead, as many have referenced today, we await the Supreme Court ruling. We understand the availability of exchanges and the discussion that just occurred, individual responsibility requirements that will be a part of the future, essential benefits that were referenced by earlier presenters, as well as other major impacts that will come in the future years. But with that, we must not overlook the healthcare cost challenge that's facing our nation and what still needs to be done to finish the job that we started with healthcare reform. As the Supreme Court has listened to the challenge of healthcare reform, and we expect a ruling possibly in late June, with that, the court is considering whether the individual mandate is unconstitutional. As one of our speakers referenced earlier, basically there are 4 possible outcomes. The court might rule in favor of the law and uphold the individual mandate. They could rule in favor of the law except for the individual mandate that would leave all other provisions intact. They could rule against the law, striking it down, or they could delay a decision by determining that the courts can't yet review the mandate. However it occurs, Humana awaits the decision, and we are committed to following the guidance once it is received. According to the Centers for Disease Control, there are almost 50 million Americans who currently are uninsured. The Congressional Budget Office has made projections, as well as the CMS actuary. And by either accounting, they do project that over the next decade with healthcare reform, there would be over 30 million additional people that would gain coverage, but yet there would still be over 20 million who would be left uninsured. While most agree that the new healthcare reform law will cover more Americans, many believe it does little to address the underlying medical costs that continue to rise at an unsustainable rate. So what the law lacks really is a system-wide approach that would actually bend the cost trend of medical costs. So as we look at these experts and we look at these cost projections, we are stating what we believe. As Humana, we believe that all Americans deserve affordable, quality health care coverage, but that cost control is critical to achieving that goal. Humana has long said that it will take bipartisan concepts and cooperation to solve our healthcare cost crisis. We need to find ways to move forward to healthcare solutions in a constructive manner. Humana has a unique vantage point at the hub of the healthcare system. Because we connect the system, we see the whole picture, and we recognize that providers, patients, and purchasers of healthcare all have to work together to overcome our healthcare cost crisis. We must promote competition and preserve consumer choices. To make every healthcare dollar count, we need an active, competitive healthcare marketplace. Health insurance is not a one-size-fits-all. People should be able to choose the plan that is right for them, even if that plan happens to be the plan that they already have. We also must help Medicare and other public programs overcome their cost challenge. And then finally, we must ensure a smooth and stable transition into 2014. If we are to create a sustainable healthcare system for the future, we really have to finish the job. Here's Humana's perspective on what must be done to ensure that our healthcare system is sustainable for the long term. Cost control and sustainable behavior changes must be part of the nation's top priority list. After all, healthcare services really account for 96% of all healthcare spending. We need to attack the underlying cost of health care, and here are a few ways that we need to do it. First of all, we need to measure performance and disclose results, and this applies to all of the system stakeholders, including the insurers. We must hold ourselves accountable for making progress. We must make information available to consumers so that they can make educated, cost-conscious health care cost decisions. We also should align incentives to reward value. We should be demanding high-quality outcomes at low cost and not rewarding simply based on volume. We need to reduce fraud that drags down our system, continue to promote the sharing of best practices in an attempt to eliminate needless and costly variations in care. And then finally, as was referenced by Bruce Greenstein earlier in the day, we really need to attack the underlying public health problems of obesity, inactivity, and smoking. As much as 70% of the U.S. healthcare dollar goes to preventable chronic diseases such as diabetes, asthma, and congestive heart disease. We also should do a better job in applying technology, connecting the system to reduce errors and to reduce redundancy. And with these, all of us in this room have a role to play. So at Humana, we're working to make sure that lawmakers don't forget that there is much more to be done to truly solve our healthcare cost crisis. So I thank you for your attention to these introductory remarks, and I look forward to being part of the panel discussion. Thank you.
Commissioner, let me commend you on the crowd that you have here. I remember a few years ago, or several years ago, doing this, and your predecessors were here. And by this time of the agenda, the folks that were left, I felt like I was having a staff meeting. Because the only folks that were left were my employees, who were required to stay and hear me speak. So
it's greater interest this year.
Yeah, so much greater interest and great job of getting the folks here. So our topic this afternoon was the impact of private health insurance market as a result of healthcare reform. Well, the impact is huge. It affects our products. It affects how we contract with our medical providers, with our physicians, with our hospitals. It affects how we do our financials, both internally and externally, with our DOI reporting and our financial reporting. It impacts our distribution system. It impacts the tools and technology. So across the board, healthcare reform touches so many aspects of what we do. So an incredible amount of change. So if I could, and I guess this is the thing here. I guess if I could rely on our old friend Yogi about and use a Yogiism that federal reform impact, the future ain't what it used to be, is where we're seeing it. So I promise that will be my only entrance into comedy this afternoon. So in any case, let's just talk about if we do have change, that where are we today? 157 million employees and dependents access it through their employers. Well, we know that. Individual benefits, 14 million, and that's today. That's the sweet spot, through employer-based health care and through individual. Then we have those that are accessing it through Medicaid. We got 46 million of those. Retirees, which is a growing population, that's 43 million. And then 50 million, and then that census or that amount seems to vary depending on the course. This does happen to come from the U.S. Census Bureau, so we'll rely on that as a fairly true assessment of the uninsured, is around 50 million. So, but where it's going to affect, and I talked about the sweet spot, the 157 million in employer-sponsored, and then there's the individual, and then we expect to see a change in the Medicaid population as well. So that's the distribution where we are today. Well, where is it going? The expansion of coverage is major. And going back to, what we wanted to share with you this afternoon is, how does our business change? Well, once again, our business will change substantially. So we'll see that today, give or take, there's that 50 million uninsured. We anticipate that by 2014 to 2019 that there'll be an additional 32 million that will be insured. There's still an actual 18 million that will be unaccounted for, and they will fall. But when we say, well, what's going to happen? Where is this expansion going to occur? Look at commercial or employer and individual-based coverage. You can see that that's going to increase from 171 million to 187. So there'll be a 16 million population increase in employer or commercial business. In the government, and this is very specific to Medicaid, it would also be a 16 million increase. So once again, when we talk about how will our business change, well, we'll see an opportunity that an additional 16 million folks in that individual and employer market, and then we have to align, does it make sense for us to get into that Medicaid? Here at United, we are in the Medicaid business, and I'll just do my quick United commercial. We are a Fortune 21 company. We have 80,000 employees. employees. We touch about 80 million Americans here in Louisiana with our new Medicaid contract that through Bayou Health, we are up to about 650,000 members in lives. So while we recognize that having the large local in scope, healthcare is delivered locally, so that local in focus is very, very important to us. And that's why when we talk about these types of expansions, we feel that it's important for us to play in each of those arenas or in each of those spaces as much as possible. Now we've got all of these folks that are going to be entering the system through the employer individual market into the Medicaid market, so 310 million people accessing it into a system that already has pressures. So there's the 93% and the 7%. Well, we've seen that all over the board. You know, we've got the MLRs at 80 and at 85. I just happened to take the Center for Medicare and Medicaid Services, CMS, and the Office of Actuary to use these titles. But the fact is you've got $2.4 trillion being spent in healthcare. And so now all of these folks are going to be shifting into a system that is already struggling. It's already struggling from an access standpoint, and it's already struggling from affordability standpoint. So that's the system, or that's the pressure that our system is going to be under as we, that middle part, the insurance and related, the financing, the distribution, the care management, all of those things, we are trying to align our resources to do as best job as we can to take care of that demand with the supply that we have that's left to us. So once again, that's where we see our business changing and try to fit into that. Now, we've got all these folks coming, and these are, you know, that is where they're moving to a system that's already under pressure. Well, we're also a nation that needs wellness. So all of those individuals that will be coming in, this says 100 and every 100 employees, that could be every 100 citizens. We know, and most of us have seen these statistics before, that 67 are overweight or obese, 50 have high cholesterol, 39 don't exercise, 33 suffer from stress and anxiety, 25 have high blood pressure, and 21 smoke. Interesting enough, 10 years ago, 30 of us smoked, but then if we look over the past 25 years, adult obesity has doubled. So I guess that old tale that we had that if you stop smoking, you gain weight, you know, maybe that does come true. But the sad part about it is the next one, and that is childhood obesity has tripled. So obesity alone is responsible for increasing annual health care by $200 billion. So once again, business is changing. Our system is going to be under a lot of pressure because we've got more of these folks that will be entering the system that have these types of issues and conditions that we have to deal with. But overall, we have to have the tools and technology to create a nation that we are focused on wellness. So post-reform roadmap. How we are entering in a whole new marketplace. We talked about the shift with the addition of Medicaid, the addition into the individual and the employer market. We have to solve for the affordability will mean engaging consumers to make their better decisions. And we've all heard of that. We've all experienced and been part of the consumer-driven plans and HSAs and HRAs and high-deductible plans, and really the focus on tools and technology. But now more than ever, with folks that will be entering the system who have not been in it before or have been in the system through other areas or have not purchased or acquired insurance in the same way, will now have to be focused on all of these tools and technology to help them become more involved in their choices so that we can deal with the costs and benefits. So the new care delivery models are going to need to be focused on quality care and reducing waste. No question about it. We need to bend the trend through better health delivery services, quality-based health decisions, efficacy and safety. And then we have to explore, I talked about before, our ability to contract with our providers, our physicians, and with our hospitals. So performance-based, that's the PBC acronym, but performance-based contracting, working with accountable care organizations and other value-based contracting is going to be very important. It's going to be important to us as commercial insurers, and obviously it's going to be important to the providers as they see changes in Medicare as well. Once again, substantial changes as a result of federal reform in how we go about our daily business. Just to step back a little bit, and once again, going back to our topic of how do our businesses change, well, I talked about the shift. We talked about the shift in the population, more folks going into Medicaid, Medicaid expanding, the individual and the insurance market, more folks becoming involved in that. So one of the things that's happening in 2012, and we've all heard about the rebate. And just exactly, well, how does the rebate work? Well, this is one slide, but let me tell you, it's a number of pages in terms of how we as a healthcare company, once again, what changes do we have to make, have to administer it. So it really starts with the rebate being involved with small business at the 80% medical loss ratio, large business at the 85% market medical loss ratio, but it's based on first by state, by license, by line of business, and by group size. So, for instance, a company like United or other companies here at the table with me, which, by the way, who's running all of the health insurance business today? But I guess we have good folks that they don't need us. But the fact is that we have multiple licenses that we would have to look at each of those intersection points. So if United Healthcare has 3 HMO licenses or 3 insurance licenses, we would have to do that same calculation on every single intersection. So you can imagine the complexity that we have in determining exactly where these rebates are going to occur. Then there's the calculation that's going to be based on the group policyholders, based on a pro rata share of the premium paid by each group policyholder in the aggregate. So all of these groups that fall into that aggregation, into that intersection, then the MLR would be examined. If it's small group and it's 80%, if we don't achieve the 80% and there's something left over, then that's a trigger for a rebate to occur. Now, in 2012, rebates start. So in just a few months, we'll be having to go through, well, already, most of us are already in the lines of working to get exactly where our rebates are. So rebates must be distributed by August 1st, or following the end of, which is following the end of the MLR reporting year. Now, some changes with respect to how those medical loss ratios are distributed, and some folks, at first it was that it was going to go to each individual enrollee, and then there was the issue about, well, how much did they contribute versus their employer, and then how much the employer contributed, are they still employed? Well, the new ruling now, except in certain circumstances, is that once that aggregation occurs, once that license, the aggregation, the group size, and so forth has all occurred, then the check, that rebate check, will then go to the employer. It would go to that policyholder. Then it would be up to that policyholder to determine what is the portion that would go back to the employee, and what is the portion that would be responsible, or would actually be the employer's, because they contributed toward that insurance. Then it's also going to be incumbent upon the employer to locate those employees that may be no longer employed with the company that would fall into those categories. Now, how would does the employee write a bunch of little bitty checks? Well, obviously that's an option that they can do, or they actually could look at other alternatives to get those rebates back to them. Some of them may do it in premium credits. They may lower their their employee contribution for subsequent years. So there is a number of ways that they can look at it. But how is our business going to change? In 2012, MLR is going to be a big change to our business, and getting these things out. And I know we have many producers here in the audience today. Many of your clients are going to be dealing with as these first rebates come out on August 1st. So just a little bit there. Then what about 2014? How does our business change? Well, everyone thinks about 2014 as the exchanges, and we had great presentations today from a number of folks that talked about exchanges and the public exchange and what's going to happen at the state. We know our issues and that we're dealing with, and our position as the state of here in Louisiana on exchanges. But the fact is that these things are going to be happening in 2014. But it's not just exchanges. It's guaranteed issue. It's individual mandates. It's employer mandates. It's cost-sharing subsidies. It's essential health benefits. It's co-ops. It's shops. It's other exchanges. There are so many things that that the 2014 market provisions will require us to do. Substantially, our business will be changing in 2014 as a result of these. If you look at some of the highlights, 30 million newly insured individuals by 2014, perhaps 80 million switching coverage sources. So those who have not gone out on their own to locate and find and purchase coverage are going to have to do it, or if they've received it in other forms, if they've received it to their employer, they may have or their only option may be to go out into the exchange market themselves. But what the estimate is that 80 million will be switching coverage. 20+ million will be purchasing through exchanges. exchanges. The number covered by Medicaid increases by 15 million because we know the subsidies will be happening. The average subsidy of $5,000 to $6,000 per enrollee, and then the Medicaid primary care reimbursement will be increasing to the Medicare rates in 2013 and 2014. Wow, a lot. A lot happens other than just exchanges, which we still have a lot to do to figure out exactly how each of the exchanges will operate, both at the federal government, at the federal level, as well at the state level. But a lot of things happening in 24, once again, that will significantly impact our business. So if you can imagine, and we talked about the size of our organization, but you can imagine the resources and the investments that we've had to make in order to be able to administer all of the aspects of the reform program. It's substantial, it's massive that we're having to deal with. So our business is changing as a result of this. Obviously, I'm not going to go all through this, but we looked at what are some of the key reform issues, and I'll just hit on the top one. So this is obviously a little bit more editorialized from United's perspective, but from an exchange standpoint, exchanges should promote fair and efficient markets with a level playing field for all plans. And I'll just mention a couple of these: promote competition, choice, and innovation in product offerings; prevent adverse selection; apply the same open enrollment period rules to both inside and outside of the exchange. So just a couple of things associated with exchange that we believe are imperatives. MLR. Well, we feel that we should either repeal or alternatively modify MLR provisions to avoid market disruption. Grant waivers of MLR requirements for the individual market, extend the MLR waivers to the small group market, and include fraud prevention programs, cost, and associated with all payer databases within the definition. So putting more things into what goes into that 80 or that 85% MLR calculation. We had a great discussion on rate review. Our belief is that we ensure rates are based on consistent, objective, actuarial-based standards that reflect the underlying drivers of healthcare costs. So, the reform is huge, and the Affordable Care Act is huge. But there are so many points that sometimes you just have to drill it down and say, what are the givens? What are the 4 or 5 or 6 priorities that we have to get done? And so if we had to break it down into these key issues, exchanges, the essential health benefits, MLR, and rate review or where we see those. And then lastly, this will be, once again, not necessarily a commercial, but, and I won't go over them all, but 6 core principles for healthcare modernization that we believe, and I'm just going to point out 3 of them. Build upon the foundation of employer-based health coverage. It's worked for us for many years. It's what you guys do by and large, being able to be that representative of the employer and doing your jobs to make sure that they are that they are out in the marketplace, that they are getting competitive quotes, that competition is out there. You're being a good source as a consultant to them. So we want to build upon the foundation of employer-based coverage. And then if we drop it down to modernize Medicare and Medicaid, I think is an imperative as well. We're already seeing on the Medicaid side with Bayou Health and Secretary Greenstein and what's happening with that. That was a big bite of the apple that we took there. That was a big move on the part of our state, but clearly it was a needed move. We're ranked 49th in health status. We're not moving. A lot of that health status is coming from our poorer population, our Medicaid population. So modernizing Medicaid and certainly on Medicare as well is going to be a key essential to healthcare modernization. And then the last thing is something we strongly believe in, and that is make information and technology an enabling force for better care, to provide individuals with more information so that they can make better decisions and ultimately have better outcomes and better health. That's the bottom line of where we are. Folks are not, we looked at those statistics, we know where Louisiana ranks, we don't want to go through all of the different aspects of it, but the fact is that folks need the information and they need to begin to engage in the things that they do. So to sum things up, there's a lot going on with what we have to do as health insurance companies in the balancing act of both continuing to grow our companies, continuing to create new products, continuing to work with our distribution systems to make to see what works best for our clients. So a lot of things are going on as a result of it. And so, Commissioner, we appreciate the opportunity, and I look forward to our panel discussion.